Good evening, everyone. Welcome to this webinar entitled How to Perform and Interpret Peripheral Arterial Doppler Examinations, presented by Dr. John Pellerito. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to discuss techniques and protocols for duplex examination of the peripheral arteries, utilize diagnostic criteria for identification of significant arterial stenosis and occlusion, and identify findings associated with pseudoaneurysm and AV fistula. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. John Pellerito and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. John Pellerito.
Okay, thank you, Darcy, and welcome everybody. Good afternoon, good evening, wherever you're coming from. I'm so glad that so many of you can join us today. And before I start, I want to thank Darcy and the AIUM team for inviting me to do this webinar today. So Darcy has already reviewed some of the goals and objectives for this presentation. So what I'd like to do for the next few minutes is go over my approach to the performance and interpretation of peripheral arterial studies. Obviously, we'll focus on diagnostic criteria for arterial stenosis and occlusion. I'll review some technical tips that I find very helpful. And we're going to finish up by talking about pseudoaneurysm and AV fistula, which I think at sometimes can be kind of difficult to distinguish. So when we think about the evaluation of the peripheral arteries, there are a number of diagnostic tests that you can employ. In our practice, we routinely use the ankle brachial index, as well as the other indirect tests, which we'll be discussing in a moment. And of course, we focus on the duplex examination. But we also can utilize magnetic resonance angiography or CT angiography, or perhaps less commonly arteriography for evaluation, as arteriography is typically reserved these days for treatment rather than diagnosis. So here are a number of different indirect tests that we routinely use, and I find them very helpful, particularly the ankle brachial index. The ankle brachial index obviously compares pressures at the level of the brachial artery to pressures obtained at the ankle and give you an idea of whether you have normal blood flow or not by recognizing changes in pressure from one side to the other. As you can see from this illustration that we have blood pressure cuffs placed at numerous locations around the lower extremity, which allow us to detect changes in blood pressure as we move down the leg. We also have these waveforms that we see flanking the blood pressure cuffs, and these are pulse volume recordings. And these recordings, they assess the pressure pulse. So when there's blockage to blood flow, we'll see that there's a decrease in the height or the amplitude of that pressure wave. And that also can be very helpful, as we'll see. And of course, we can always obtain Doppler waveforms. And for those patients with claudication, we may challenge them with a treadmill exercise test before and after we take their pressures to see if there's evidence of underlying disease. So we use these indirect or physiologic tests for screening and also to demonstrate the level of disease if we want to focus on a particular area of abnormality. So here's one of our cases. Here's a 60-year-old with left leg claudication. And you see I put a box on the left side because this is the abnormal side. If you look at the bottom of the scan, you'll see the ankle brachial indices. And it's practically normal on the right side, where it's 0.98. We typically consider anything near 1.0 to be normal, as the pressure should not drop as you go from the arm down the leg. But you'll see that on the left side, it's only 0.61, so it's significantly decreased. And if we look at the pressures next to the cuffs, we'll see we go from 190 millimeters of mercury and it drops to 115. Now, we shouldn't have much more than a 10 to 15 millimeter difference. And if you look at the other side, if we compare sides, you'll see it's a big difference as it goes from 115 here to it's 180 on the other side. So certainly a significant decrease in pressure in the left leg at that femoral popliteal level. And also notice the change in the pulse volume recordings. Nice tall waveform at the thigh level, but there's a decrease in the amplitude as we move down to the calf. So that decrease in the pressure and a decrease in height tells us that there is going to be a lesion somewhere along the course of that femoral popliteal segment. And again, here's just a close-up view showing the change in the pressure, which we see here as we go down the thigh. And you'll see it drop significantly here from 190 to 115, and of course the change in the waveform height as we go from the thigh to the calf. Typically, the calf has even taller waveform compared to the thigh, but here we see it's definitely decreased. So we can use that information in a number of different ways. We can choose a specific Doppler protocol once we know the level of interest. So the two types of Doppler imaging protocols that we can utilize in our evaluation would be a mapping of the lower extremity, which would be an evaluation of the complete lower extremity from the aorta down to the legs. You can take it as far down to the ankle if you like, or you can do a Doppler evaluation that's focused to the level or segment of interest that is defined by these other tests. So for example, in the study we just reviewed, we saw that there was a focal decrease in pressure and blood flow on the left femoral popliteal side. So if we wanted to do just a focus study, we could just study and take images from the left thigh to the calf. So when we do these exams, whether it's a mapping or focus study, we utilize all the different ultrasound modes. And the way I think about it is that we use the grayscale to evaluate for the presence of plaque. Obviously, if we have a normal vessel, the vessel walls are smooth and thin with no evidence of echogenic material within the lumen. And then we use the color Doppler to assess for normal or abnormal blood flow. By optimizing the color Doppler, we can sweep the vessels very quickly looking for areas of abnormality, such as narrowing or aliasing. And then finally, of course, we're going to use pulse Doppler, and we're going to take velocity samples at different arterial segments. And if the blood flow looks linear and it looks laminar, then we can probably just go from specific segments like common femoral, superficial femoral popliteal. But if we see abnormal blood flow, if we see aliasing, then we're obviously going to take additional samples in the areas of flow disturbance. So for our arterial mapping, we may want to start up high at the level of the abdominal aorta, and you can see in the image it's a sagittal view of the distal abdominal aorta branching into the right common iliac and the left common iliac. And you can appreciate that the blood flow is nice and homogeneous. There's no evidence of disruption, turbulence, or aliasing to suggest an abnormality. And then we can then just move down into the lower extremities and get our samples from the common and external iliac, take samples from the common and superficial femoral arteries all the way down to the popliteal artery and trifurcation branches. Again, going as far down as we think necessary to get a complete examination. So we can use either the linear or curved array probes depending on the depth of the vessel. For example, if we're starting in the abdomen, we want to see the abdominal aorta, we're going to probably use the curved array transducer at a lower frequency so we get good depth penetration. But most of the time when we scan the extremities, we then will switch to the linear probe, which is going to give us better resolution at a higher frequency. And of course, we can switch back and forth depending on the size of the leg, size of the patient, to get the best images. We optimize the grayscale and the color Doppler parameters. Again, I like to change the PRF or the color velocity scale so that we have a nice homogeneous color signal in normal areas of blood flow. When we've optimized to the normal areas, then it's very easy to detect flow abnormalities and areas of stenosis or occlusion because we'll see the change. So to do that, we need to adjust the pulse repetition frequency to normalize flow. And then, of course, we're going to take our pulse Doppler samples at multiple points, and particularly in regions of color aliasing. As we see here in this example, where we see that there's an alias signal in the distal superficial femoral artery, disturbed flow distal to it. So we want to get the highest peak systolic velocity to grade the lesion. So we're going to place that sample volume inside the lumen, angle correct to the direction of blood flow in the vessel to see what the peak systolic velocity is at that point. So what I want to emphasize is that in order to get an optimized study, you need to make sure you've adjusted your color gain, your PRF, so that you can easily see flow abnormalities when they occur. You want to make sure that the size of the sample volume is relatively small and fits within the lumen so that you don't have a lot of extraneous noise in your sample. And you want to make sure that you angle corrected to the direction of blood flow. And notice here, we're perfectly corrected at 60 degrees. And we can go from 60 degrees or less, but never over 60 degrees because that is going to increase the error in our measurement. Notice in this particular waveform, nice how clean and crisp it is. We can easily see the peak systolic velocity. The area under the peak is clear. So this is a nice normal waveform. So this is where we really want to focus on what normal peripheral arterial flow looks like. We say normal peripheral flow is triphasic. In other words, we see these three components. We have our initial forward flow component in systole. This is our high velocity component. And this is related to ventricular contraction. The heart contracts, sends a bolus of blood down the lower extremity. It's going to give us the highest peak systolic velocity. And this is what we use to try to determine if the blood flow velocity is in the normal range or not. And then we see this early diastolic flow reversal. And this is related to peripheral resistance because blood flow now has to cross from these larger caliber vessels into smaller vessels, into branches and arterioles and capillary beds. There's resistance to blood flow, and that causes reversal early in diastole. Finally, we have this late diastolic forward flow component, which we see here, and we believe this is related to elastic recoil. As the red blood cells move down the lower extremity, they initially distend the walls, which then snap back into place, further propelling the red blood cells down the leg. And so we look for normal triphasic flow in segments that we believe are free of disease. Any aberrations or changes from this pattern are abnormal, and we have to try to figure out why that's occurring. Besides looking at the waveform shape, we also are going to look at the area under the curve. And if we have a nice sample volume placed within the lumen, angle corrected in a normal vessel, this is typically a clear space underneath the systolic component. And then finally, of course, we're going to look at the peak systolic velocity. And in this popliteal artery, we see the peak systolic velocity is about 60 centimeters per second. So now we know what normal is. And we can start applying that to some of the cases that we see. Here's an example of a sample from the common iliac artery. And again, notice angle corrected to the direction of flow. And we have a triphasic waveform. Note that we have a peak systolic velocity is about 100 centimeters per second. Nice clear systolic window. Similarly, we can look at the branches of the upper extremity arteries. And here's a sample taken from the right subclavian artery. And again, it should also be triphasic. And here we see triphasic flow in the normal right subclavian. Also important to remember what the normal peak systolic velocity ranges are. So whenever you get samples in a study, just by looking at the velocities, you get an idea of whether they're in the normal range or not, giving you some insight as to whether there may be underlying disease, even before you look at all the examples, all the sample that you get. So for the femoral arteries, we typically say that the peak systolic velocity is going to be about 80 to 100. And it could be up higher, it could be 120 or so, it might be a little bit lower, but this is an average. As we move down the lower extremity, the velocities are going to decrease. At the level of the popliteal arteries, it's about 60 to 80 centimeters per second. And as we move then down further into the tibial branches, it's about 40 to 60 centimeters per second. So make sure you jot that down. Have this as a handy reference when you're looking at peripheral arterial studies, because the velocity measurements should be within these ranges for these particular vessels. So as we go through some cases, the way I want you to analyze the pictures that we have is to think about whether the waveform is normal. Is it triphasic? What is the peak systolic velocity? And do you have a clear spectral window? Here we have a normal waveform that was obtained from the superficial femoral artery. Peak systolic velocity is about 80 centimeters per second, normal triphasic waveform. So let's talk a little bit about the criteria we use to classify peripheral arterial disease. We break it down into mild, moderate, severe, and occlusion. So a mild lesion takes into account about a 1 to 19% diameter reduction. That's about 1 to 19% narrowing of the lumen. And we're going to see mild changes, right? When we look at this example of a mild stenosis in the left popliteal artery, we see that the waveform still looks triphasic, but we're starting to see some fill-in of the spectral window, and the velocity is elevated. Here it's up to 145 centimeters per second. Now, in order to grade the lesion, what we need to do is compare the velocity in the stenosis to the normal proximal segment. So when we do these studies and we find a lesion, we'll take the peak systolic velocity there, and then we're going to march the sample volume back into the normal segment, take a velocity measurement there, and see what the increase is. When the increase is up to 29% compared to the normal proximal segment, we say it's mild stenosis. For the moderate category, we'll see further increase in the peak systolic velocity, now up to 99% greater than the normal proximal segment. So again, in this example, we have a stenosis in the superficial femoral artery. Place the sample volume there, it's angle corrected, the velocity is about 166 centimeters per second. We will then march the sample volume back into the normal segment, get that velocity, and if it's almost double but not quite the peak systolic velocity, we'll say it's about a 20 to 49% lesion or moderate disease. The key here is that there isn't a doubling of the peak systolic velocity, so the ratio is less than 2 to 1. Notice that the waveform maintains its triphasic appearance. And that's really important because the triphasic waveform will distinguish whether you have a mild or moderate lesion or a severe stenosis. And so when you have a significant lesion, a severe flow-reducing stenosis, which we characterize as greater than 50% narrowing, we have a change in the waveform shape. It's no longer triphasic. If you look at this example, here we have a tight stenosis in the superficial femoral artery. If you look at the color display, you'll see there's some aliasing there, clearly some plaque, narrowing, and the peak systolic velocity is almost 450 centimeters per second, clearly more than double the peak systolic velocity in the proximal segment. So analyzing this waveform, we see it's no longer triphasic. There's flow only in one direction. And for that reason, some of us call that monophasic. There's flow only in one direction through the stenosis. Because there's a pressure drop distal to the stenosis, the red blood cells are basically sucked through the lesion, so there's no reversal. There's going to be spectral broadening or filling in of that waveform, at least a doubling of the peak systolic velocity. If the ratio is 2 to 1, we say it's a 50 to 75% stenosis. If the ratio is greater than 4 to 1, then we say it's a 75 to 99% stenosis. And that's how we classify the degrees of severity. One of the other significant factors that you can look for to confirm it's a flow-reducing lesion is by continuing to move the sample volume into the poststenotic area, and you will see poststenotic turbulence. And I'll show you some examples of that. Obviously, if there's an occluded segment, we'll see flow up to the level of the occlusion, and there should be no flow on the color display beyond the occlusion. If we sample right before the obstruction, we can typically see this very high resistance, low velocity waveform. Look how abnormal this is. We can see blood flow is going in, it's hitting the obstruction and just stopping. So the velocity here in this common femoral artery above the occlusion is only about 20 centimeters per second. And there's no flow in diastole. So this is very consistent with outflow obstruction, and that's why I'm going to spend so much time talking about it. When you see these high resistance waveforms, particularly when they're very low velocity, think about an obstruction. Think about an occlusion or a very tight stenosis. So there'll be absence of flow in the occlusion. The proximal flow that we're capturing here, very high resistance, typically low velocity. And when we sample below it, if there is reconstitution, typically from collaterals, we will see a low resistance flow pattern, such as in this particular case. So here's an example of collateral flow trying to bypass an occluded segment. And here we see low velocity waveforms with this very slow rise to peak systole. This is the classic tardus parvus waveform. And what this means is a very slow flow going in, velocity is low, slow rise to peak systole, telling us there is an inflow lesion. So if we just go back for a second, notice with the occlusion, proximal to it, we have a nice rapid systolic upstroke. The inflow is good. But when we have the slow rise here, that means that there was a problem with the inflow. So with these two different waveform shapes, you can pretty much tell where the lesion is occurring. So let's take some more examples. Here's a 49-year-old diabetic, smoker, history of an MI with 1 block claudication. So here are the indirect studies, and notice I put the ABI down in nice block numbers, 0.83 on the right. Not normal, but it's not terrible. And the ABI on the left is 0.46, very, very low. And of course, when we start to look at the pressures, we'll see there's a significant difference, a big decrease as we move down the left thigh. And also notice that the waveforms have changed. We're losing amplitude. And it's always helpful when you look at these studies to compare both sides, particularly when one side is relatively normal, as it is on the right. We see a normal amplitude in the right calf, decreased amplitude in the left. So very quickly telling you where the level of abnormality is. And this is particularly helpful for us if we have the capability of doing these studies, so we can really focus on the area of abnormality on our duplex study. Here again is a magnified view showing that the pressures go from 164 to 102 across the thigh, and that we lose amplitude on the pulse volume recordings. So here's the duplex examination in this patient. So we're starting out at the level of the groin, the common femoral artery, triphasic waveform, peak systolic velocity is 86. So far so good. Looks like, and we have a nice rapid upstroke, so it looks like it's telling us that the inflow is okay. So we're going to move down the leg. And as we cross into the superficial femoral artery, we start to see changes. Notice that there's plaque, narrowing of the lumen. The color Doppler shows us that there's aliasing, right? This change in the color flow pattern. The aliasing indicates wraparound. We go from red to yellow to white to blue. That's what we're seeing here, due to the increased velocities across the segment. And when we place the sample volume, we search for the highest velocity, which in this case is 256 centimeters per second. So we went from 86 in the normal proximal segment to 256, about a 3-to-1 increase in velocity. Again, putting us in that 50 to 75% range. As we go beyond the stenosis into the popliteal, notice now very abnormal flow. The velocity is low. We said it should be somewhere between 60 and 80 centimeters per second. Here it's only 36. Waveform, very abnormal, not triphasic, low velocity, slow rise to peak systole. The tardus parvus waveform, TP shaped, tells us there's an inflow lesion, just in case we missed it. So when we perform these studies, we look for these specific color flow findings to tell us there's underlying peripheral arterial disease. The focal color change that we see at the site of the stenosis is related to aliasing or wraparound because there's a focal increase in velocity across that segment. Other things we can see, color bruit artifacts due to perivascular tissue vibration. In other words, when you have a very tight stenosis, the red blood cells moving at such high velocities cause the tissues around the lesions to vibrate. And they vibrate at low-level frequencies, which produce a color flash bruit in systole, which I'll show you in a moment. And of course, if we go downstream, we're going to see a turbulent pattern, and that presents itself as a color mosaic on the color display. So here we have an example of a stenosis in the posterior tibial artery. The still image here shows us there's calcified plaque, there's narrowing, there's aliasing. I've slowed down the color Doppler sequence here so you can appreciate in systole that you see that there's aliasing that's occurring across the stenosis. Again, if I turn the color off, you'll be able to see the plaque. With the color on, we see the narrowing and the aliasing, telling us where to place the sample volume to get the highest velocity to grade the lesion. When we take a velocity sample there, we could see it's about 356 centimeters per second. High velocity, not triphasic, spectral broadening, or complete fill-in of the spectral window. All the abnormalities that define a significant stenosis. Now here's an example of a color bruit. And again, I've slowed it down a little bit. And notice in systole, you get all of this flash that occurs because the velocity is so high it's causing the tissues around here to vibrate at low-level frequencies. The machine isn't smart enough to know that's not blood flow, so it paints color around the tissues. This is one of my favorite artifacts because when I see a bruit, I know there's an underlying vascular problem. It could be a stenosis, or it could be a fistula, or perhaps the neck of a pseudoaneurysm. It's indicating it's a very high flow state. High velocity flow causing the tissue vibration, producing a color bruit. Here's another example of an occlusion here, distal superficial femoral artery. See the abrupt cutoff of flow. Here we're seeing a collateral coming off. And I'm showing you the MRA in this case, which is showing the abrupt termination of blood flow. This is calcification. Here's the abrupt termination of flow on the contrast study, and here's that collateral coming off. So very nice correlation between the duplex exam and the MRA. Actually, this is CTA because of the calcium. We can see the calcium. Okay, so peripheral Doppler findings in peripheral arterial disease. We're going to be looking for elevated peak systolic velocities in the stenosis. We look for loss of the diastolic reversal, the bruit on a spectral display, and the tardus parvis waveforms in the poststenotic area. So I've already discussed with you the appearance of the color bruit, but we can also see a bruit on our spectral waveforms, and we can look for that as an additional sign of a high-grade lesion. Here's an example of a stenosis in the right common femoral artery. Again, the color Doppler showing us pretty pronounced color bruit artifact in the common femoral artery at the site of the stenosis. So we can see there's aliasing and that flash telling us this is where the lesion is occurring. This is where we need to place that sample volume and move through there. On the spectral trace, we can see the velocity is about 414 centimeters per second. High velocity, monophasic, loss of the triphasic signal, spectral broadening, and here is the bruit. Notice that these artifacts are occurring in peak systole. That's how we know these are bruit artifacts. This is the correlate to the colored Doppler abnormality. Right at the baseline. These are low-level frequencies that we see right near the baseline. Okay, so here is a same patient. So we're moving down the leg, had a high-grade stenosis in the right common femoral, and you see the velocities decrease to about 93 centimeters per second in the mid-superficial femoral abnormal waveform. As we continue down and map the abnormalities in this leg, we'll see that as we move into the mid portion of the SFA, the velocities increase again. So there's about a doubling of the peak systolic velocity at this level, indicating a second lesion. And then I'm going to move down into the popliteal, and now the velocities are really low. They're about 30 centimeters per second, and we see that tardus parvis waveform. So again, indicating to you that there was significant proximal disease. It didn't tell us how many lesions there were. We found at least 2, but telling us there was proximal obstruction. So here's some take-home points, clues to the location of disease. If you see this low velocity tardus waveform, then you know there's got to be an obstruction upstream, and you look for it. If you see this low velocity high resistance waveform, notice good systolic upstroke, but marked decrease in flow or absence of flow in diastole, that means the obstruction is downstream, further down the leg. Let's take a look at this case. So here's an elderly patient, presents to the lab with rest pain, had an abnormal indirect study, and we're starting at the level of the common femoral artery. And right off the bat, we notice that the waveform is abnormal. So take a look at it. What do you see? What makes it abnormal? Well, first of all, it's not triphasic. Second of all, it's got some spectral fill-in. And third of all, the velocity is too low. And we expect to see velocities over 80 centimeters per second at the level of the common femoral artery. This is about 37. So the next question I have for you is, where is the lesion? Is it proximal to this, or is it distal to it? That might be tricky for you, but one of the things that I do, first of all, is I look at the upstroke. If it has a good rapid systolic upstroke, then I'm considering the inflow is good, the lesion is likely downstream. So let's take a look. Here we're moving down to the proximal superficial femoral artery, and what do we see? Lots of disease, narrowing, and now the waveform is even more abnormal in the sense that the velocity has further decreased. It's extremely slow at 14 centimeters per second, no flow in diastole, but it maintains its rapid systolic upstroke. Again, indicating to me that the inflow is okay and that the lesion should be downstream. So let's keep looking. Let's find the lesion. So based on these waveforms, if you had to guess where the lesion would be, Would it be at the level of the external iliac? Probably not, because the inflow is good based on the upstroke. Common femoral artery? Nope, didn't see it there. Superficial femoral artery? Well, that's possible because it could be further downstream, or it could be at the level of the popliteal. So as we continue down and look at the rest of the superficial femoral artery, we see it's occluded. As we look down here, we see that there are collaterals coming off, but no flow in the superficial femoral artery, so it is occluded. The lesion was further down, as we suspected. And as we move further down the leg, we notice that the popliteal artery is also occluded. Here, this is a color Doppler image. We see calcification in the wall, but there's no flow. And because pulse Doppler is more sensitive than color, we're going to place the sample volume in there, make sure we've reduced the PRF or the velocity scale so it's very sensitive. We're going to also make sure that the wall filter is really low, so if there's any flow in there, we want to pick it up, and we don't see any flow. So we have an occlusion of the superficial femoral artery and the popliteal artery in this patient. This patient went on to correlation with MRA, and just as we thought when we looked at the study, the inflow is okay. Here's the abdominal aorta, and here are the iliac arteries. And although there are some atherosclerotic changes, these inflow vessels are fine. There is no proximal lesion here. We look at the common femorals, they are fine. Here we start to see the bifurcation, and here's the rest of the MRA of the lower extremities, showing abrupt cutoff of the superficial femoral artery. Here is some blood flow in the deep femoral and some collaterals, and you can see there's some collaterals further down the level of the calf, but the SFA and the popliteal artery are occluded. It looks pretty good on the contralateral side. This next case is a 70-year-old who presents with a history of one block claudication. So let's go through this together. We're going to start at the level of the external iliac, and we have a peak systolic velocity of 78 centimeters per second. How's the waveform? Looks pretty good, right? We have triphasic flow. Velocity range maybe a little bit on the low side, but so far so good. We move down to the common femoral. Velocity is 86. Lower range of normal. And the waveform is still triphasic. So again, I think so far we're doing pretty well. With a good rapid upstroke, I think the inflow is okay. So we're going to continue to move down the leg. As we hit the superficial femoral artery, then we start to see disease. The velocity is 288 centimeters per second, so it's almost a threefold increase. Again, that puts us in that 50 to 75% range. Lots of spectral broadening, and we're starting to lose the triphasic appearance. Let's continue down. Distal to that, the velocity goes right back down again. So it was 288, and then when we get distal to the lesion, it drops to 88. One of the things I want you to notice, look here, there's a collateral coming off. So there's probably further disease. And as we go down into the level of the popliteal artery, we see that the popliteal artery is occluded. No flow on the color display, no flow on the spectral trace. So already we have multiple lesions. And then if we skip all the way down to the area of reconstitution where those collaterals come back in, we see low velocity flow in that popliteal artery, classic tardus parvus waveform. Again, indicating proximal disease. And if we skip further down to the foot and look at the dorsalis pedis, well, we see the dorsalis is wide open. So we're obtaining this sample right on the dorsum of the foot. And the dorsalis and the velocities are 18 centimeters per second. So patent, but low flow, and again, classic tardus waveforms. Let's take a look at this case. 66-year-old male, high blood pressure, diabetes, right leg pain. The sample from the common femoral artery, triphasic flow, velocity is 78. So far so good. As we move into the deep femoral, also looks pretty good. Triphasic flow, no elevation in the velocity. Superficial femoral artery, proximal, also normal waveform, normal velocity range. Patient has leg pain, diabetes, We have a high index of suspicion in this disease. We continue on. This is the distal SFA. Velocity is starting to drop. Waveform remains triphasic. Popliteal, also triphasic. Velocity is about 70. So far we haven't found any focal disease. But once we get into the calf, we start to see multiple lesions. Here in the posterior tibial artery, toward the distal calf, we have a high-grade stenosis, almost 390 centimeters per second. Again, not triphasic, spectral broadening, high velocity. Some of this stuff we see here below the baseline is related to Bruy artifact. There's also disease in the perineal. The perineal artery is occluded, and it has reconstitution distally. The anterior tibial artery appears occluded. And there's some reconstitution, and we can start to see some of those collaterals coming in. And as we go to the dorsalis, again, we see that there is diffuse disease, narrowing. There is some flow. It's abnormal. It's low velocity. And we do see some of those collaterals trying to bring blood flow back to that ischemic leg. Okay, let's move on to some other things. Here's a patient that presents with a pulsatile mass in the popliteal fossa. So everybody knows what this is, right? We're dealing here with a popliteal artery aneurysm. And this, on this sagittal view, we can see that we're measuring the residual lumen, and of course we're going to measure the size of the aneurysm, outer wall to outer wall, just like we do with the abdominal aorta. So this is something that we see fairly commonly. Patients present with a pulsatile mass behind the knee. Popliteal artery aneurysms are the most common peripheral arterial aneurysm, and they're the second most common aneurysm after aneurysms of the abdominal aorta. It's a strong male predominance, and again, as I mentioned, presents as a pulsatile mass. Now, this aneurysm measures about 2.5 centimeters. The normal size of the popliteal artery is less than a centimeter. And we don't tend to call an aneurysm until it's at least 1.5 to 2 centimeters in diameter. One thing to remember is that popliteal arteries are frequently bilateral, at least in about 50% of cases or greater, and at least 30 to 40% of patients with popliteal aneurysms will have a AAA. So if you see popliteal aneurysms, think what's going on with the patient's aorta. Some quick things I'd like to cover as we start to wind down is some of the criteria that we use for patients after intervention or revascularization. So there are specific criteria for evaluating vein bypass. Dr. Dennis Bandick has been a pioneer in the field, and he's come up with the criteria looking for a significant stenosis in a bypass graft when the peak systolic velocity is greater than 300 centimeters per second, or we have a velocity ratio. Again, the peak systolic velocity in the stenosis compared to the peak systolic velocity in the proximal segment greater than 3.5. These are consistent with a significant bypass stenosis. Here's an example of a 58-year-old. Status postfemoral posterior tibial bypass. I'm just showing you this example. There's obviously a stenosis at the distal anastomosis of the graft to the posterior tibial artery. Aliasing tells us where the abnormality is. We place the sample volume there, and the peak systolic velocity is 420 centimeters per second. We also have criteria for evaluating patients following angioplasty. And again, we have peak systolic velocity criteria. Greater than 50%, the velocity is between 180 and 300. Greater than 70% stenosis, we say the velocity is greater than 300. We also use velocity ratios. Again, greater than 50% is greater than 2 to 1. And greater than 70% is greater than 3.5 or 4 to 1. Similar to what we do with the native peripheral arteries. Some people also use end diastolic velocity criteria. And if the velocity is less than 45 centimeters per second, that is worrisome. And that is also a criterion that is used for bypass grafts. Finally, just to talk a little bit about peripheral stents, here are some criteria that are used. And if you go through the literature, you'll see that there are multiple criteria proposed. But here are some criteria that you can certainly put by the workstation to try to evaluate the degree of stenosis. Greater than 50%, we say somewhere between 200 and 275 centimeters per second. Greater than 80% stenosis is when the velocity is greater than 275. And again, the ratios are similar to what we were talking about earlier. Greater than 50%, 1.5, 2 to 1, up to about 3.5, which is consistent with a high grade or greater than 80% stenosis. I have two examples here at the bottom. Here we have a patient that has a high grade stenosis, an in-stent stenosis, where the velocity is about 250 centimeters per second. And here's an example of a patient with a thrombosed stent. And here you can see the stent filled in with low-level echoes. There's no flow, and we see a collateral. One thing to remember is we can use the same criteria when we evaluate the upper extremity. So here's a quick case: 68-year-old with right arm pain, and we're looking at the right subclavian artery. The first thing I want you to recognize is that the waveform is abnormal. Just like the lower extremity, waveform should be triphasic. And in this particular case, we see it's not. Not only is it monophasic, or flow in one direction, it's got a very slow rise, right? Slow rise, TARDIS appearance, indicating there's a proximal or inflow lesion. So that's the first clue that there is a significant proximal lesion. Now, here is the contralateral side. Here's the normal left side, just for comparison. Triphasic, normal velocity, right? The velocity is 46 on the abnormal side. Normal side, it's about 80. Now, let's take a look at the right axillary. You can see that the abnormality persists, velocity is relatively low, still TARDIS parvus, only telling us that the lesion is going to be proximal to that subclavian. Now, we need one other piece of information. What's going on in the common carotid? Now, you may ask, why am I showing you that? Well, it's going to narrow down the area of abnormality. Because if you have an abnormal subclavian lesion, it's possible it could be coming from the thoracic aorta, it could be coming from the innominate artery, or it could be coming from the subclavian artery. If the lesion is coming from the aorta or innominate, it should affect the proximal common carotid. And we see a normal upstroke and a normal waveform here, so that's unlikely. So if we had to choose where we think the abnormality is, we can narrow it down from these two waveforms. We've ruled out the thoracic aorta because the proximal common carotid artery waveform is normal. We've ruled out the innominate artery for the same reason. It would affect the common carotid. We know it should be somewhere in the subclavian because it's affecting the subclavian. The axillary artery and brachial are distal to the lesion, so the correct answer would be C. So obviously we went after it and tried to find the lesion, and we noticed very significant turbulence in the most proximal part of the subclavian artery that we could see. So we actually didn't get very high velocities, we just got very turbulent flow. So we then resorted to the CT scan, and the CT scan showed marked calcification and narrowing right at the origin of the subclavian artery, telling us that that was where the lesion was, right at the origin of the subclavian. The innominate was fine. So I'm going to finish up here with just a very brief discussion of femoral artery injuries, because I think it's important to recognize these findings, even when they're unsuspected. And what I'm going to do here is compare and contrast both pseudoaneurysm and AV fistula. Now, I know most of you are familiar with these entities because they're not uncommon, and you see them from time to time, typically after patients have had an interventional procedure, whether they're coming from cardiac cath or had some other puncture of the femoral artery for an intervention. And so we recognize pseudoaneurysm as a vascular mass that is connected to the underlying artery by a tract or a neck. And again, it results from a hole in the arterial wall, typically from a procedure, less commonly from other forms of trauma, like a stab wound. And the pseudoaneurysm is formed by the surrounding soft tissues and hematoma. It's not a true aneurysm. It's a pseudocapsule surrounded by tissue and blood. So in real time, we see this swirling color flow. And if we freeze it, we get this sort of yin-yang appearance that we say is typical of the pseudoaneurysm. And we'll try to identify that tract or neck which communicates between the feeding artery and the pseudoaneurysm. If we sample in that neck, we are going to get the classic to and fro flow pattern. We only see it in the neck. If we sample inside the pseudoaneurysm, we're just going to see turbulent flow. And what the to and fro pattern represents is a high velocity jet that enters in systole, and then there's reversal that occurs during diastole. And this is what it looks like on the spectral trace. Place the sample volume in the neck, flow goes in systole, reverses during diastole, to and fro. The common method of treatment these days is thrombin injection if the patient has suitable anatomy. So here, these are the different options. Very small pseudoaneurysms, about 1 centimeter or less, we tend to watch because they can spontaneously thrombose. Very large growing pseudoaneurysms may go for surgical repair. Less commonly, we will resort to an ultrasound-guided compression repair because we typically will treat those patients with a thrombin injection if they're suitable candidates for compression. And of course, if they're in an unusual location or have an unusual anatomy, we may do some other type of interventional technique, such as a balloon occlusion. Many of you are familiar with thrombin repair. Basically, we stick a 22-gauge needle into the pseudoaneurysm cavity under ultrasound guidance. We inject thrombin into the pseudoaneurysm while we watch it. Remember, that's an off-label use of thrombin because thrombin is not intended for intravascular use, but it has proven to be a very fast and effective treatment for the repair of pseudoaneurysms. And here's just one of our cases from our series. Here we see a common femoral pseudoaneurysm. Here is the artery. The neck is in here. After the injection, you can see we've converted it into a hematoma. Now, just a few words about AV fistula. They're less common than pseudoaneurysms. Again, typically seen after some type of procedure. The most common that we see is typically resulting from a communication between the common or deep femoral artery and the common femoral vein. Sometimes they can be very complicated. Here we can see, blood flow coming from the artery, and it sort of takes this circuitous sort of winding path to finally empty into the vein. So sometimes it takes a few minutes to sort it out. If the fistula is really large, it can result in ischemia or congestive heart failure. And these are the types of waveforms. If you place the sample volume in the fistula, you see classically high velocity, low resistance blood flow. So having velocities over 100, 200, 300 centimeters per second, not unusual in these fistulas. What we expect to see is continuous blood flow between the artery and vein. Like I mentioned to you before, color-Bruy artifacts, very common. And if you freeze it in diastole, the Bruy goes away, and it's easier to see the communication between the artery and the vein. I think the diagnosis relies on the waveforms that you obtain. When you sample the artery feeding into the vein, you lose the triphasic pattern. Again, high velocity, low resistance. And if you sample the vein, it's no longer that nice phasic pattern, it's arterialized. So these two findings allow you to clinch the diagnosis. And here's just one of my favorites. I call this my rainbow fistula. And we can see this was likely caused by crossing punctures, one into the artery, one into the vein, producing this arc of blood flow going from the arterial side into the venous side. The arterial side is now high velocity, low resistance because it's feeding the vein, lost the triphasic pattern. The venous side is now arterialized. So to finish up, I want to show you a couple of interesting cases, which I think are kind of challenging. And the reason that I want to show them to you is because these are pitfalls that I've been seeing lately that I think you should be aware of. Here's a patient that presented after cardiac cath, and they had a pulsatile groin mass. And you can see here from the color Doppler image, it looks like there's this locule that's projecting from the common femoral artery. And here it looks like a neck, and there's flow swirling inside this area. And of course, we love using power Doppler. We turn power Doppler on, and here's what it looks like. And so I think most of us think it looks like a pseudoaneurysm. And of course, the sonographer performing the study also thought it looked like a pseudoaneurysm. And here's the sample from the neck. And you can see the label presumed it was a pseudoaneurysm. But the one thing I want you to notice is the waveform in the neck is not to and fro. What we see here is a high velocity, low resistance pattern. The fact that it's on both sides of the baseline just indicates it's a mirror image artifact, and that this is really not the waveform we'd expect in a pseudoaneurysm at all, but rather the waveform we'd expect in a fistula. So that's got to prompt you to look a little bit further down. And if, as we stretch it out, we can see, wait a minute, here's that neck feeding the cavity, but then there's a communication with the vein. So this is a complex fistula with a pseudoaneurysm component. The most important part to recognize here, you do not want to inject this with thrombin, because then the thrombin is going to thrombose the venous system. It's going to go right out of the pseudoaneurysm component right into the vein, causing thrombosis. And again, notice the classic fistula waveform. Finally, this is a fun case. 85-year-old pulsatile groin mass. And I was called to see this patient because this was very confusing. The still image shows sort of this little mushroom-like cloud of color, and here is the appearance. So one of the problems we had is, where is the feeding artery and vein? Sort of difficulty trying to assessing where this was coming from, and we sort of saw this swirling color flow. So after taking a look at it, we put the Doppler on this area, and we have this high velocity, very low resistance flow pattern. Not at all what we'd expect from a pseudoaneurysm, but again, suggesting there's probably a fistula somewhere. Now, when I put the probe down, this is what I saw. I saw this artifact. Looks like color rain, just raining down on the soft tissues. So again, seeing a Bruy artifact, I know we're dealing with a very high flow lesion, so it's a matter of trying to figure out what the anatomy is. And as I worked on it a little bit further, I'm able to demonstrate that this is a very complex fistula. And again, we have blood flow that is coming from the arterial side, and it's wrapping around into the deep venous system. So what we're dealing with here is a complex fistula. And once we've identified the anatomy, artery, vein, this is the fistula. When we sample it, we get the high velocity, low resistance pattern. So something to keep your eye out for. When you see that pattern, think fistula and try to figure it out. So that's it. I'm sure my time is up, and I appreciate your attention. I think that, from looking at some of these cases, I've shown that the indirect studies, at least in my experience, are very helpful for screening for arterial disease. If we have normal ABIs, normal indirect tests, probably no need to go ahead and spend the time doing a duplex study unless you have a patient with claudication. Duplex and color Doppler I found very helpful for characterizing focal lesions, monitor disease progression. We use it to direct appropriate intervention, defining what the abnormality is, trying to help the cardiologist and the vascular surgeon determine what the appropriate therapeutic response should be. And of course, we use it to identify complications of treatment. And with that, I'm going to stop there. Again, appreciate your attention. I'll hang around and take on any questions that you may have.
We've got one question.
Okay, I see only part of the question.
Okay.
Oh, here it is. Can the waveform of the carotid give us insight to a dissection of the proximal aorta? And the answer to that is yes. It may not work on all occasions, but if there's any obstruction to blood flow coming from the thoracic aorta, then you may see an abnormality in the waveform. It could be reduced velocity. It can have a TARDIS configuration because there's outflow obstruction. So abnormalities in the carotid waveform usually will, especially if there's a delayed upstroke, indicate there's a proximal lesion. Sometimes you get a break and you can actually see the flap extending from the thoracic aorta into the proximal common carotid artery, so you can see extension of the dissection. But to answer your question, yes, you will definitely see some abnormalities in blood flow in the waveform when you have a dissection of the thoracic aorta.
Okay, and I guess that's a wrap. So thank you very much, Dr. Pellerito. And on behalf of the AIUM, our thanks to all of you who participated in tonight's webinar. Please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.